Hi guys, so welcome. Now I do understand that you're preparing for the exam. Exam is just around the corner and you're going through stress. So I will not take too much of time. You have already studied the topics like diabetes, COPD, asthma. This is just a quick update on extra things that you need to know from the updated guideline before you get into the examination hall. So we'll spend 5 minutes on each guideline and we will concentrate on the key points that you need to remember, right? So we're going to talk about the guidelines with respect to asthma and then COPD and then for the diabetes ADA. Okay, so we will begin with the asthma guidelines. For asthma we follow what is called as Gina guidelines, Global Initiative Against Asthma. Okay, so what is the major change in 2025? As such, there is no much change in 2025. So if you have studied from the previous guidelines, you are still good to go. Nothing major changes. Only 2-3 points you need to remember. In the older guidelines, for patients who are not having frequent attacks of asthma, we used to use SABA alone also as a possible reliever treatment. Now the current guidelines, 2025 guidelines recommend that we should not be using SABA alone. Now there may be two patients of asthma, one having asthma attacks daily, he needs a regular preventive medication, and another patient once in a while is getting asthma attack, so he will require only a reliever medication. But whether it is a preventive treatment or reliever treatment, patient should always get a combination of. So the guidelines recommend using combination of SABA plus inhaled corticosteroid. Means no asthma inhaler should be given without an inhaled corticosteroid. That is the first take home message. Regardless of the severity of asthma attacks, frequency of asthma attacks, if you are giving an inhaler should have an inhaled corticosteroid. That's the first message. Okay. Then second, 2025 guidelines introduce a term which in the previous guidelines we used to call it as MART, maintenance and reliever therapy. Now it is called as SMART, which stands for single maintenance and reliever therapy. Means we are using a single drug for relieving an asthma attack, and that means single inhaler. The same inhaler is also being used as a maintenance medication. So what is that? It is a combination of formoterol plus inhaled corticosteroid. So this is the treatment of choice for asthma. We give them a combination inhaler of formoterol plus inhaled corticosteroid. In one inhaler we have formoterol plus inhaled corticosteroid. Whether patient is going through an attack and you want to relieve it quickly, or whether you want to use it on a daily basis for prevention, this is the medication to go for, and we call it as SMART. Okay. Now the question is, for which patients I should tell them to use inhaler as and when required and no need for a daily basis, and for which patients I need to ask them to use inhaler on a daily basis, right? So for that, this is a table that I want you to by heart. Initial treatment of asthma according to Gina guidelines 2025. So on one side we have the symptom status, and on the other side what should be the initial treatment. Okay, symptom statement, we will have steps. We will always do a stepwise approach to initiation of the treatment. Okay, for those patients who are getting asthma attacks very infrequent, means when I say infrequent, less than 2 attacks of asthma per month, less than 2 attacks of asthma per month. So for such patients there is no need for use of inhalers on a daily basis. So what we would recommend them, we will recommend them to use, PRN refers for as and when required. As and when required, combination of SABA, short acting beta agonist, plus inhaled corticosteroid. So that's the main essence, right? That's what I told you. If someone is getting an attack of asthma, to relieve, we should not be giving SABA only. We should always give it with inhaled corticosteroid. So if it's like, okay, once a month I get asthma attack, or maximum twice a month I get asthma attack, in that case I will have an inhaler which contains a short acting beta agonist and inhaled corticosteroid in the single inhaler. Whenever there is an attack, I will take it to relief. That's it. As and when required. PRN here refers to as and when required, not on a daily basis. But if I'm getting asthma attacks more than 2 per month, but less than daily, what do I mean by that? Like let us say I get 3 attacks per month, 4 attacks, 5 attacks, 10, 12 attacks. But you can't say that I'm getting it on a daily basis. If I'm getting on a daily basis, monthly it should be 25 plus, then I can call it as daily basis. But if I am getting more than 2 but not on a daily basis, such patients we will start them on step 2 treatment. In step 2 treatment, we will either give them a daily low dose inhaled corticosteroids for prevention of asthma attacks, or we will give a combination of formoterol plus low dose inhaled corticosteroid. Formoterol plus low dose inhaled corticosteroid. Now what about those patients who are getting asthma attacks on most of the days, on like kind of daily basis, or even if a patient is being made to wake up in the night because of the asthma attack at least once per week, such patients require daily low dose inhaled corticosteroid plus formoterol combination. Okay. Now the same features, means almost every day patient is getting asthma attack, or at least once a week he is waking up with asthma attack, and when PFT done his FEV1 was less than 30% predicted. Story same with FEV1 less than 30% predicted. These patients will require to be started on medium dose inhaled corticosteroid plus formoterol. Inhaled corticosteroids plus formoterol. This is how we start the initial treatment for asthma according to 2025 Gina guidelines. Now this table seems complicated, right? Difficult to remember. We will try to make it simple. We will have a simple approach. Okay, so this is not what guidelines write, but this is what I'm going to make it as a simple approach. So whenever I'm having an asthma patient, right? So what I should see is asthma attacks more than or equal to 5 days per week. That is what I can call it as asthma attacks on a daily basis, almost on a daily basis, or more than or equal to 1 nighttime attack or nocturnal attack where he is waking up because of asthma per week. Okay, this is the question that you need to look for the answers in your MCQ. Like whenever you get an MCQ where the examiner is asking according to Gina guidelines what should be the initial treatment, try to find the answers for these questions. Look for whether he is getting asthma attacks 5 times a week or more, or whether he is getting 1 nocturnal asthma attack making him wake up. If the answer for this question is yes, let us say yes, this patient wakes up at least once per week because of asthma attack, or he is having asthma attacks on a daily basis. That's one possibility. Or another possibility is no, sir, this patient does not have asthma attacks on a daily basis. If the answer is yes, according to this table, where he will fit into, he will fit into this group, right? This group or this group. These are the 2 possibilities. If the answer is no, he will either fit into this group or this group, right? So in that case, what should I do? If the answer is yes, in that case the patient requires to be started on, as you see here in the table, either low dose combination of inhaled corticosteroid and formoterol, or medium dose inhaled corticosteroid and formoterol. What is the difference? If the FEV1 is low, I start with medium dose. If FEV1 is fair, I start with low dose. So what I should do in that case? Here, next thing I should do, if the answer is yes, I will look at the FEV1. And if FEV1 is less than 30% of the predicted value, and if it is more than 30% of the predicted value. If it is less than 30% of the predicted value, for these patients I should start them on medium dose inhaled corticosteroid plus formoterol combination. Formoterol inhaler, of course, on a daily basis. And if it is more than 30%, then same medication, but we will start with daily inhaler of low dose inhaled corticosteroid plus formoterol. So when do we decide to give daily inhalers? If they are having attacks almost every day, or nocturnal attacks once per week making them wake up in the night because of asthma attack. Okay, now if the answer is no sir, he is not having daily attacks and he is not waking up in the night, so then he has to be either in this category or this category. Now what is the difference between 2? If they are getting less than 2 attacks per month, then as and when required inhaler. But if they are getting more than 2 attacks per month, then daily low dose ICS or formoterol. So what I should do in that case here? Here, if that is the case, then I should see whether it is less than 2 attacks per month. Daily to nahi hai, that's why we have called it as no. Whether they are having less than 2 attacks per month or more than 2 attacks per month. Okay, so if it is less than 2 attacks per month, our approach is going to be as and when required. If it is less than 2 attacks per month, as and when required, not on a daily basis. If it is less than 2 attacks per month, we will treat them with a combination of, the treatment will be PRN, means as and when required, combination of SABA plus ICS. Means these patients will keep an inhaler with them. Whenever there is an attack, they will take it. But if there is more than 2 attacks per month, these patients need to be on daily inhaler. That can be either, they can be either daily low dose inhaled corticosteroid or daily low dose inhaled corticosteroid plus formoterol combination. This is the approach to start the initial treatment for asthma patients according to 2025 Gina. So if you remember this flow chart, you will always be able to decide what should be the initial treatment for a clinically oriented MCQ. That is the main update with respect to Gina. Now let us look at what will I do if with all these medications the patient is not controlled. So in this Gina guidelines, we have this step 1, 2, 3, 4. So we'll start the treatment according to the symptom status, whichever step the patient fits into. So if patient is not responding to step 4 treatment also, then we go for step 5. And in step 5, what do? We can either consider adding a long-acting antimuscarinic agent. They would be already taking a LABA, or we can consider biological treatment. Biologicals means monoclonal antibodies. Like what? We can consider giving them omalizumab or dupilumab. I'm just listing few. In your pharmac books you will study more. Dupilumab, mepolizumab. So these are biologicals which can be considered for the step 5. Okay, so that's about Gina. Now let us look at the guidelines for COPD. What is the major change? No major change as such this time. Okay, so here also they will ask you, okay, here is a case of COPD. According to the GOLD guidelines, what should be the initial treatment? So whenever we have a patient of COPD, before we decide the treatment, we have to categorize them into 3 categories, A, B and E. Okay, now how do I categorize them into A, B and E? All you have to do is read the question and try to find out the answers for these questions that I have mentioned here. Whether in last 1 year, means if I am seeing the patient today, in the past 1 year's history, whether he had 2 or more than 2 moderate exacerbations, or whether he had 1 exacerbation which required him to get admitted. If the answer is yes sir, this patient had 2 moderate exacerbations in last 1 year, or if he was like within last 1 year he was admitted once because of COPD exacerbation, then the answer is yes. And it's like, no sir, he did not have 2 moderate exacerbations, he had no hospitalization, then the answer is no. When the answer is yes, there was an admission or 2 moderate exacerbation, the patient will be put in what we call as category E. This question is looking at the history of exacerbation, and if exacerbations were significant, he will go into category E, which stands for exacerbation category. That's why it's called as E, right? A, B, C is not there, E is there because this is exacerbation category. Bar exacerbation ho raha hai, COPD is getting worsened. And if the answer is no, then he has to go into category A or B. Okay, so how do I decide whether he should go into category A or B? That will be based on, we will look at the dyspnea grade, severity of shortness of breath of the patient, using what we call as Modified Medical Research Council grade. So if the dyspnea grade is more than or equal to 2, or whether it is less than 2, that is 0 to 1. If it is more than or equal to 2, the shortness of breath grade, then he will go into category B. And if the shortness of breath grade is 0 to 1, he will go into category A. Category A. So we have 3 major categories, and once we have learnt which category this particular patient belongs to, then we can decide the management. Okay. Now we will take a small question on this to decide the category before we learn about the management. So let us say that I am having a COPD patient, a case of COPD, and this patient had one admission related to COPD 3 months ago. So 3 months back he was admitted because of COPD exacerbation, and his modified medical research council grade of dyspnea is grade 3, right? Now the examiner wants to know which category patient belongs to according to 2025 gold guidelines, according to gold 2025 guidelines. So what do you think? Is it category A, B or E? Options in front of us are option A, it's category A, option B, category B, option C, category C, option D, category E. So what do you think? Lubna Kausar, good. Which category this patient should belong to? Lubna Kausar, what you are listing is the grade of COPD. Grade does not influence the management. What influences is the category. So which category this patient should belong to? What is that I need to know? Whether patient had 2 or more than 2 moderate exacerbation in 1 year, or whether he had 1 hospitalization in last 1 year. So here in last 1 year patient had 1 hospitalization. So for this question my answer is yes or no? Yes. So which category he should go into? Category E. Whenever these kind of questions appear, many times students go for category B as the answer. Why? Because they saw the MMRC grade and it is 3 in this question, right? 3. So they will jump to say that, sir, MMRC grade 3 means it is more than 2, so it should be category B. The answer is no. Why? Because there is a protocol that we just learnt. First thing I should see is exacerbation. Exacerbations significant hai, satisfy this question. Then MMRC grade does not matter. I should not look at the MMRC grade, directly label it as category E. MMRC grade comes into picture only when exacerbations are insignificant, when we get a no answer for these questions in the patient story. Only then, to differentiate between A and B, we look at the MMRC grade, right? MMRC grade is otherwise not relevant when it comes to category E patients. So here, yes, we are dealing with, the answer here is category E. We are dealing with category E patients. Okay, so now we know how to categorize the COPD. Next is, according to gold guidelines, how do we manage COPD? Management of COPD, or I can say initial management of COPD according to gold guidelines 2025. Okay, so we have 3 categories, right? So what we will do is category A, B and C. Okay, so for category E. So for category A patients, where, see, when you look at this category A, what is their problem? Do they have severe exacerbations? No. Do they have severe dyspnea? No. They are mild, right? These patients have severe exacerbations. And category B patients, they don't have severe exacerbations, but they have severe shortness of breath. So for grade A, I don't need to do much. So for category A, any bronchodilator, means you can use any of the LAMA or LABA. Any bronchodilator can be used. For category B, single bronchodilator is not enough. We need to use a combination of LAMA plus LABA, LAMA plus LABA. And for category E patients, we can use again, because these are having severe exacerbations, we should use LAMA plus LABA. And one extra point to note here is that if eosinophil count of the patient is high, eosinophil count of the patient is high, that is more than 300 per cubic millimeter, then in such cases, what should I do? I should continue with LAMA, continue with LABA, but in addition to that, I will also include inhaled corticosteroids, because eosinophils are causing inflammation, adding steroids help. So an MCQ that I can expect from this is that when do we go for triple therapy according to GOLD guidelines 2025? So we go for triple therapy for category E patients with high eosinophil count. Otherwise, here and here it is dual therapy. For B and E patients with normal eosinophil count, it is dual therapy, LAMA plus LABA. And for A patients, it's single therapy, either LAMA or LABA. Clear? So this we can call it as, so please, I want you to remember, this we call it as triple therapy. Triple therapy. Just like how you have triple therapy, quadruple therapy for H. pylori, here also you have triple and double therapy. So here it is dual therapy for B and E with normal eosinophil count, but E with high eosinophil count, we have triple therapy. For A, it's a single therapy. You can either use a LAMA or you can use a LABA, one of them, not both required. Clear? Okay, so that's the summary of our GOLD guidelines 2025. No major changes from the previous years. Okay, I will take another 3-4 minutes to give you a quick update on the ADA guidelines 2025. Again, no major changes per se. Pharmacology and advancement in the drugs that you have already studied in pharmacology. Key MCQs that I can expect from the ADA guidelines with respect to diabetes is that the diagnostic criteria, target HbA1c, and assessing the glycemic control. So diagnosis of diabetes, no major change. We will call it as diabetic if the FBS of the patient is more than or equal to 126 milligrams per deciliter, or if the HbA1c is more than or equal to 6.5, or 2-hour postprandial glucose is more than or equal to 200 milligrams per deciliter, or if RBS is more than or equal to 200 milligrams per deciliter with signs and symptoms of diabetes, or you can say symptomatic of DM, or patient presenting with diabetic crisis. So we'll just try to understand this in 2 minutes and then we will discuss about the other parameters. FBS should be more than or equal to 126 milligrams per deciliter, or HbA1c should be more than or equal to 6.5, or 2-hour postprandial glucose. When I say 2-hour postprandial glucose, that means randomly taken blood sugar after 2 hours of eating any random food. No, it is after taking 2 hours postprandial glucose, means after taking 75 grams of anhydrous glucose. Means we are giving glucose dissolved in water, we are not giving any meal. It is similar to glucose tolerance test. 75 grams of glucose patient takes, 2 hours later we check the blood glucose, and if it is 200 or more, it is diabetes. But if you take someone's sugars randomly, like okay, now I am taking the class, it is not, I am not fasting, I have not gone through this 2-hour postprandial, you take my sample randomly and it turns out to be more than 200. It is not usually diagnostic, but if I have the symptoms of DM, means polyuria, polyphagia, polydipsia, or weight loss. Symptomatic refers to 3 P's of diabetes: polyuria, polyphagia, polydipsia, and weight loss. If these symptoms are there, then you can call me diabetic. If these symptoms are not there, you can be suspicious that I may be having diabetes. You still need to go for FBS or HbA1c or the 2-hour postprandial glucose to diagnose. But if I have the symptoms, you don't need to do these tests. Just based on a random sugar, you can diagnose. Or if I present with diabetic crisis, what are the diabetic crisis? Diabetic ketoacidosis or hyperosmolar hyperglycemic state. If I present with these, like let us say in the emergency room, you got a patient whose random blood sugar is 300 and he's having a metabolic acidosis on the ABG, urine ketones are positive, right? Should I diagnose him as diabetic tomorrow after doing the FBS, PPBS? No. Patient is in diabetic crisis. With that reading of 200 plus is sufficient enough to diagnose him as diabetes. Okay. And once someone is diagnosed as diabetes, when we start treatment, what is the recommended target HbA1c according to Gina guidelines 2025? The recommended target HbA1c is less than 7% for most patients. For most patients means what? If patient tolerates to go that low, try to go that low. But if patient does not tolerate, means he is experiencing hypoglycemia when we try to control further, in such cases we can look at less than 8%. Less than 8% if patient is at high risk of hypoglycemia. High risk of hypoglycemia, like elderly or with organ dysfunction, where trying to achieve tight glycemic control may result in further hypoglycemia. Hypoglycemia can be as dangerous or life-threatening, so we don't want to go there. So in such cases, we will go at 8%. Try to keep it less than 8%. But for everyone else, less than 7% is the target. Yes, 7% is the target, but if there is hypoglycemic risk, then 8% is the target. Okay. Then what is the preferred mode? Like once I started some anti-diabetic medications, I want to achieve this target, but is this the preferred mode of assessing whether the blood glucose level is well controlled or not? The answer is yes. In the past, the preferred method of assessing whether the glucose is controlled or not, we started with checking FBS, PPBS and controlling. Then we went with HbA1c. So what current guidelines recommend? Current guidelines recommend using continuous glucose monitoring, CGM, over HbA1c. So when CGM is possible, do CGM. If CGM is not possible, then we go for HbA1c. What do I mean by CGM? CGM refers to continuous glucose monitor. Some of you might have seen in one of the previous classes few months back, I was wearing a small device on my arm, right? That device is a continuous glucose monitor. So there will be a small device with a tiny needle which will be placed in the subcutaneous plane, and it will continuously record your blood glucose levels. It will give me a literally 24-hour graph. How much was it in the morning, before breakfast, after breakfast, how much was it at, let us say 12:30, 1:30, 2 o'clock, 4 o'clock, night, early morning. 24 hours of recording. Generally we get a recording for 2 weeks or 14 days with one continuous glucose monitor device. After that you have to remove and then stab one more device for the next monitoring. That is a preferred method because that will clearly tell you when it increased, when it came down, after what meals it increased, what meal you are tolerating well without sugar spikes, what meal you are not tolerating well. So that's a preferred method, but of course it brings cost. It costs around 4,000 or 5,000 rupees for 2 weeks. Not all can afford. So in those cases, we can go ahead with HbA1c. Abhishek Singh, you can ping me your details on the Telegram. I will talk to you. Okay. So this is about the ADA guidelines. So the key points that I want you to remember here, which I sense that they can ask as MCQ, is with respect to the asthma management. Most likely they will ask you two things. What is a major change, or is it allowed to use SABA alone for the treatment of asthma? No longer SABA alone is recommended because SABA alone is associated with increased risk of recurrent attacks. If I give, let us say, salbutamol inhaler to the patient, he takes it, he gets relieved now, but the next chances of next attack increases. So SABA alone is associated with increased risk of further attacks. But if I had given a SABA in combination with an inhaled corticosteroid, the corticosteroid will reduce the inflammation and reduce the chance of further attack. That's why SABA alone is not recommended. That is first point I want you to remember. Then the term MART is replaced with SMART, which stands for single maintenance and reliever therapy. That is basically the same inhaler being used to relieve attack as well as to prevent attack. Okay. Initial treatment you can address based on the flowchart that we made. Please remember this. This is a potential MCQ zone. Apart from that, with respect to COPD, I want you to learn to categorize. The trap when it comes to categorization is MMRC grade. MMRC grade you should think of only when patient does not belong to category E. If patient fits into category E, don't think of MMRC grade, just label it as category E. Okay. And from the diabetes, mostly the anticipated question is going to be either they will give the story and ask you whether he fits into the diagnosis of diabetes or not according to the ADA guidelines, or they may ask you what is the target HbA1c. They may revise the question and ask you that, okay, there was a patient who was aimed for getting the target HbA1c of less than 7, but during that process he had multiple hospitalizations with hypoglycemia. Then what should be the new target? In that case it is going to be 8%. Or they may ask you what is the preferred or currently recommended mode of assessing the glycemic control in a diabetic patient. It is going to be continuous glucose monitoring. Okay, so that's it from me here. Please go through these notes, which will be available to you on the Telegram. If you want to know more in detail about these guidelines, ping me and I will share you my summary of the detailed guidelines. But for the upcoming exam going students, these are the key points. I don't want you to waste time trying to learn in detail guidelines. Unlikely that those questions will be asked. Okay. And if you want me to cover any specific topic in the upcoming Telegram or YouTube sessions, let me know through Telegram or Instagram, and I will try to align our team to cover those topics as well. Okay. Study well. All the best. See you soon.